Good morning, friends.
One test one.
शुरू कर दो ना? Okay, good morning, friends. Well, we are back with another lecture on the respiratory group of diseases, and today we'll be discussing a disease which was rampant in India and all over the world, and today is coming back, but with a difference. Diphtheria is a disease which is an acute infectious disease which is caused by toxigenic strains of Corynebacterium diphtheria. It's a vaccine preventable disease, and that is how we have been able to control this disease. Please remember these words: toxigenic strains, and these toxigenic strains are the ones which will cause toxins, and these toxins will be the one which will produce various types of complications in human beings, complications which we used to lead to death. Now, as you know, Corynebacterium diphtheria, you've already studied it, is a gram-positive, non-motile, non-sporing organism which grows in low flows medium, and you use Albert stain for staining it. It produces a powerful exotoxin, and we have three varieties: gravis, vitis, and intermedius. The beta phage can convert a non-toxigenic strain into a toxigenic strain. So this is one of the slides which we have of the Corynebacterium diphtheria. Source of infection. Now, all people or children, especially children were the ones who used to suffer. All these children, the source of infection was cases, clinical and subclinical. Carriers were either temporary or chronic, and we had nasal carriers, throat carriers, which were there, and these would transmit the disease to other people. Carriers are individuals who have the organism but they may not suffer from the disease. The maximum risk were from individuals who are nasal carriers, and immunization does not prevent a carrier state. That is the biggest problem which is there. Immunization does not prevent the carrier state, it prevents cases only. The infected material was nasopharyngeal secretions, fomites, infected dust, discharges from skin lesions. All these things were infective materials. And the period of infectivity is, if it is a case, is 14 to 28 days. In case of carriers, they could have carried it for long periods of time, and you had to ensure that there were two cultures 24 hours apart which are negative. Then only you can declare that the person is no longer a carrier and will not infect others. Well, as I said earlier, the disease mainly affected children. But what is happening today is, with the vaccination program taking place, we are having this disease is now coming up in the elderly. We have had cases in Hyderabad of diphtheria in adolescents and adults. So we are looking at today the disease coming up in the older population. This always happens whenever there is a vaccination program conducted where children are the more prone to get the disease. The disease keeps on adapting itself and then starts involving more older age groups. Males and females are equally affected in this disease, and one infection will confer an immunity generally. The herd immunity is, as you've heard nowadays, a lot of being spoken about herd immunity. That is, a large number of population, when they get the disease, then it is likely that transmission of the disease will decrease. And for this, as far as diphtheria is concerned, the 70% herd immunity is necessary to prevent an epidemic spread. As in most respiratory diseases, it is more common in winters and mainly spread by droplet infection. And in cutaneous lesions of, we'll talk about that, cutaneous lesions of diphtheria, it can be transmitted by direct transmission. Fomites may be responsible for transmission also. The incubation period is about 2 to 6 days. And as we mentioned earlier, the exotoxin, the toxin which is there, it is the one which causes a false membrane over the tonsils, pharynx, larynx. We'll talk about this particular false membrane. It has well-defined edges, cannot be wiped away. There's a marked congestion or edema which is there. There's enlargement of the local lymph nodes. We'll talk about these things a little bit in detail a little later. Signs and symptoms of toxemia occur, and this toxemia which is there can cause away lots of complications. So, the onset of the disease is rarely sudden, and the symptoms are infrequently severe. So, you have a disease which comes on, which has a moderate temperature of 102 degrees, malaise, sore throat, and the feeling of being very tired. Sore throat is not marked initially, and this is the problem. This delays the discovery of the illness, which results in, by the time it is discovered, you find that the membrane is completely formed. The membrane formation is due to necrosis of the epithelial cells, and a serofibrinous material is liberated which forms a greenish white membrane. Very, very typical, very typical. You may be fortunate not to see it. I was in my, as you are now a student, and I was a student, I've seen a number of cases of diphtheria. Nice, you find this greenish white membrane, and then we are looking at trouble. The edges are curled or separated from the underlying mucous membrane, and if you try to remove the membrane, it bleeds. So, and there is increased toxin absorption, so you should not try to remove the membrane. Usually one tonsil is involved and soon spreads to the opposite side, and the patient who is discovered late shows extension from tonsil to the fauces to the pharynx. In mixed infection, what happens is that once the person gets diphtheria, his immunity is down, so a secondary bacterial infection can occur, and this we call as septic diphtheria. It is characterized by high-grade fever, atypical appearance of membrane, and greater inflammation in the surrounding structures. So the clinical features which we have already talked about is local inflammation, membrane formation, and toxemia. But different types of diphtheria which we have is either the tonsillar, the pharyngeal, the laryngeal, the anterior nasal, and some other forms which we will talk about, the skin ones, etc. we will talk about. The tonsillar diphtheria is the one which is most common. Initially it is a thin membranous spot, few millimeters on one tonsil. More often identified on both tonsils as greyish yellow membrane. Narrow area of redness surrounds this membrane, and tender and large submandibular lymph nodes are caused. Fauces generally is normal, but of course when it spreads, it will spread to the fauces. And this is you can see the membrane which is there in the slide. the membrane over the fauces. Here a clear cut, here you can see the membrane over the tonsils. The membranes in pharyngeal diphtheria, the membrane spreads to sides of the uvula and anterior to the teeth, most from postpillar to the nasopharynx and then to the nostril. All this area, complete area, gets covered with the membrane. The earlier membrane which is formed gets necrotic as newer parts advance. This necrotic material will smell very foul, and this was specifically called as fetororis. When bleeding occurs, the membrane becomes foul black, and this mass of tissue may shed. The throat is congested, and generally the patient, if he is not treated well in time, will have a bull neck, because there is swelling of the tissues, swelling of the lymph nodes. So all these things results in the whole neck getting swollen, what we call a bull neck. Patient is drowsy, pale and tired. This is a bull neck. If you can see the sides of this thing which is there, you have the filling up of the sides of the neck, which is swollen due to the swelling as well as the lymph nodes. The laryngotracheal diphtheria which is there is when one doesn't give a treatment in time, then it proceeds to the pharyngeal and tonsillar areas. Cough and hoarseness of voices, they may lead to loss of voice and difficulty in breathing. It extends to the bronchial tree, may cause respiratory tract obstruction due to edema and membrane formation and lead to death. Infants can have foul odor, of course. That's because, again, we talked about it, because of the superadded infection as well as shedding of the membrane, which causes a foul smell. Laryngeal diphtheria which is there is not common in all the other varieties other than the mitis, and spreads from the fauces, may spread to trachea, bronchi and bronchioles, and further it may lead to obstruction. There's huskiness of voice and a typical croupy cough. This cough is very, very typical, which is there, but please remember, differentiate this diphtheria from which is there, and we have to look at other diseases which cause cough. Which is the other disease which causes cough? You have pertussis. And pertussis causes a typical whooping cough which is there. The inspiratory distress is there, stridor. These are all similar to whooping cough. Whooping cough, inspiratory distress, stridor. What differentiates diphtheria is that you have a membrane formation. Danger of a laryngeal diphtheria is there in asphyxia, and at that time when this whole area is covered, you have to resort to tracheostomy. And the anterior nasal one which is there, you have a membrane formation which may occur in the nasal area, which causes a discharge which is initially thin and blood-stained, later turns into thick and mucopurulent. And these discharge contains a lot of the cornubacterium diphtheria, and this is the cause of a large amount of infection taking place. Spread of the infection taking place. There's a thin yellowish membrane which is there on the nasal cavity. So where else can we have other than the respiratory tract? It can go and have infection in the skin, the eye, the intestines, genitourinary system, and diphtheritic endocarditis. Let's see that. And the skin, which is common in our area, there's tropics, since mostly on the fingers and back of the hands, which spread from the when the patient tends to use his fingers possibly for cleaning his nose. That's how the fingers get infected with direct transmission of the infection, and you have punched out ulcers which will be formed. I'll show you one of them shortly. Secondary, eyes also, once he touches his nose and gets the conjunctival on his fingers, he can touches his eyes, then the person can have infection. The secondary to anteronasal infection which is there, spreads through the nasal lacrimal. It can spread through fingers or it can spread through nasal lacrimal duct. And it manifests as conjunctival diphtheria. Sloughing of the conjunctiva and corneal damage occurs, and sometimes, very rarely, you get panophthalmitis. This is skin sore which we talked about in skin dermatological diphtheria, and you can have some cases which go to the intestine secondary to the fossil diphtheria. Dysphagia and bloody diarrhea with intestinal casts are seen, usually diagnosed at autopsy, because by the time the disease is spread so much, and it's not possible just with the bloody diarrhea or dysphagia, you just can't possibly diagnose at that particular time. Urogenital system is again transmitted to fingers by contact when your person has unhygienic habits. In males, the coronal sulcus and the glands are involved. In females, the vulva and the vagina are involved. Then the dangerous ones, that's the diphtheria, endocarditis, high fatality rate, but rare. Also, it can cause cirrhosis, valves are involved. The complications of diphtheria are due to the toxin. Severe complication, nasopharyngeal and laryngeal diphtheria takes place. Earliest severe complication is in nasopharyngeal diphtheria is myocarditis. Complications are rare in nasal, tonsillar and pharyngeal diphtheria. So it's basically the nasopharyngeal variety which has more complications. Rarely you can get otitis media, albuminuria and peritonsillar abscesses. So the complications which are listed here, which we have, we'll discuss some of them in detail. Myocarditis, peripheral neuritis, various types of neuritis, paralysis of palate, diaphragm, lower extremities and extraocular muscles, endocarditis, osteomyelitis, arthritis and respiratory obstruction. As we said, the most common complication in cardiovascular is myocarditis, can be two types, early or late, and the paralytic complications can be of the palate, of the eye muscles, pharynx, larynx, respiratory muscles, limbs, heart, encephalitis. These are all complications which can occur with diphtheria. In early myocarditis, is between 3 to 7 days, peripheral damage which include pallor, rapid and steady pulse, collapse of BP, vomiting, and upper abdominal pain, which are ominous signs. Heart sounds and heart rhythm are normal. Person may go into shock due to toxins affecting their adrenals and vas deferens. Patient dies within 10 days without cardiac involvement. If the patient survives, there are signs of cardiac involvement. Late myocarditis occurs when the onset is 5 to 14 days, severe pallor, weak, slow and steady pulse. S1 is absent, S2 is soft. That's what we see in myocarditis. Heart rate is irregular and a gallop rhythm is present. And this may be accompanied with severe abdominal pain. Peripheral and spastic vasculature may have dilatation. Due to enlargement of the heart, you may have apex shifted outwards and downwards. The ECG changes are a T wave, inversion of flattened T wave, lengthening of the PR or QT intervals, and usually the patient recovers without any evidence of cardiac damage. So that's lucky that we have sometimes, if he recovers, then there will be no cardiac. If he doesn't recover, then of course. Palatal paralysis, which is there, is most common, sets in the third week and lasts for 2 weeks. Pronunciation is difficult because patient is unable to direct the lips. Eyes are, because of the eye muscles getting paralyzed, you have blurred vision, paralysis of accommodation, and may persist for a week. A convergent squint may occur due to lateral rectus muscle paralysis. A pharyngeal paralysis will result in difficulty in swallowing, saliva collects in the back of the throat, larynx is also involved, aspiration into the bronchial tree can take place. There is laryngeal paralysis can result in loss of voice, ineffective cough is present, and in limbs you have the most commonly involved are the dorsiflexors. The diagnosis of diphtheria. Now, diagnosis which must be made in time and treatment given in time for the patient to survive. So, it is necessary for control and epidemiological purposes, and treatment should be started immediately. So, you can have clinical diagnosis, lab diagnosis, and diagnosis of susceptibility. So, first is the onset of disease. As you are aware, the fossil diphtheria, thick, tough, yellowish grey membrane, which the necrosis starting, then the grey-black is in the center. Patient looks ill. Bull neck may be there in pharyngeal diphtheria. Lymph nodes are palpable or not palpable, depends. Membrane observed with a laryngoscope in laryngeal diphtheria. Dry, croupy cough is present in laryngeal diphtheria. Nasal diphtheria, there is membrane is seen along the septum and turbinates. Diphtheritic paralysis may occur. You have to differentiate between diphtheritic paralysis and polymyelitis. Be careful about that. Okay. Lab diagnosis. Swabs from throat, nose, larynx, skin and trachea exudates are cultured, and these are cultured in Loeffler's serum slopes. In doubtful cases, animal inoculation can be done by the subcutaneous route. You do a smear by Albert Spain, and serological tests are also done. So this is with Albert Stein. Virulence test. To test the toxigenicity for the bacterial examination to be complete, you have to do an in vivo and an in vitro testing. In vivo test is done on guinea pigs by giving them intravenous injection or intradermal injections. And in vitro tests are by the LX gel precipitation test and the tissue culture tests. That will be taught to you in your microbiology. Also, to detect susceptibility, you require there is the Schick test. This comes many times in the exam. Schick test is a quantitative test with regard to circulating antitoxin. Reliable test for the susceptibility useful in investigation of outbreaks, and the criteria for patients to be given immunization in adults. In children, we are giving everyone. The use of the test is the presence of the antitoxin and hypersensitivity to diphtheria toxin. What you do is you take 0.2 ml of the fluid containing dose of diphtheria toxin, and that is injected intradermally into the patient's left forearm. Similar amount of heat inactivated toxin. You inactivate the toxin by heat and inject it into the other arm. The positive is if there is a red circumscribed flush seen in the test arm measuring 10 to 50 millimeters and a peak during the 4th to 7th day, then the subject is susceptible. A pseudo-positive is the red flush occurs in both arms and is less circumscribed. That may be due to an allergic reaction, and inflammation is negative. If it is now, a person is susceptible but allergic should be cautiously immunized. If the person is negative, then if the person is negative, there is no reaction, the subject is immune to diphtheria. If there is a combined reaction, then you have to consider him susceptible to diphtheria. Now, what do you do for prevention and control of diphtheria? As is common in control, we do an early detection. You have to do an isolation, treatment. You have to notify the disease, it's a notifiable disease. The attendant should be looked after. The contact should be seen whether they have got the disease or their carriers, and epidemic measures should be looked at. So early detection involves high index of suspicion based on clinical features and bacteriological confirmation. Diagnosis by clinical examination, Albert stain, culture with low serum slope, fluorescent antibody test, toxicity test by the Alex gel precipitation test, and diagnosis of susceptibles by the Schick test. Nasal diphtheria, the differential diagnosis which should come in mind is the foreign body in the nose, rhinorrhea, and snuffles due to congenital syphilis. Fossil diphtheria, that you have acute streptococcal membranous tonsillitis, you should keep in mind. You should also keep in mind viral membranous tonsillitis, herpetic tonsillitis, thrush, and infectious mononucleosis. In today's world, where we have giving vaccines to all the children, we do not expect diphtheria to be present very commonly. Very, very rarely do we get a case of diphtheria. Hence, differential diagnosis is very, very important, and we must ensure that we do all the tests for all the various differential diagnosis, so that we do not land up stating that the cases of diphtheria and unnecessarily give treatment of diphtheria. Laryngeal diphtheria, you should remember that the person will have croupy cough. So whether it is croupy cough is very common in whooping cough, so usually you should differentiate from that. Acute epiglottitis, laryngotracheobronchitis, retropharyngeal abscess, peritonsillar abscess, and bronchopneumonia. All these do give similar symptoms to laryngeal diphtheria, and so we must be careful that we are not looking at something else and diagnose the patient as diphtheria. Now, what do we do? The principles of treatment. Remember that diphtheria is highly contagious. So the first thing what one has to do is to isolate the case and to ensure that nobody else gets the disease. So immediately on suspicion itself, the patient should be isolated. Where do you do isolation in? Do we have an isolation facility in Telangana? Yes, we have. If you every hospital requires to have isolation wards, which are there, and there is a hospital called the fever hospital or the infectious diseases hospital which we have, which has facilities for specific isolation, so we can send the person to that hospital. Neutralization of the free circulating toxin by administration of antitoxin should be done, and antibiotics should be given to eliminate the bacteria. See, Corynebacterium diphtheria is a bacteria, and hence antibiotics are very much useful in treatment of the case. Supportive and symptomatic therapy should be there for various problems which are concurrent along with the diphtheria, as well as to prevent any complications. And if complications occur, we must manage the complications. Now, where do we do the isolation? All cases should be promptly isolated for at least 14 days or until proved free of infection. At least 2 consecutive samples from the sites of lesions taken 24 hours apart should be done before the patient is sent out of the isolation, because otherwise you will have the patients whose symptoms have gone off but may remain a carrier and may go and transmit the disease in the community. So we have to ensure that 2 consecutive samples 24 hours apart are negative. And so if you're going to culture it in low flowers, it is going to take another 24 to 48 hours, and that's the reason why it will take a few days for the person to be declared free. Patient should wear the mask and dispose sputum after disinfection. Patient requires to wear a mask. The treating physician requires to wear a mask. The sputum requires to be disinfected. How is the sputum disinfected? You use hypochlorite solution. You use hypochlorite. Put in hypochlorite solution. Totally disinfect it. And then what do you do with it after that? After it is disinfected, you can very much pour it down the drain. Antitoxin. So now the antitoxin interferes with the action of the toxin and modifies that. So it's very, very important that we give the antitoxin. So it should be administered as soon as infection of diphtheria is suspected. Giving it by intramuscular or intravenous injection. After, very, very important is to test for the sensitivity to antitoxin. After administration of the antitoxin, the patient is observed closely for any decrease in the symptoms and in toxemia. Dosage depends on the duration of illness and extent and severity of the illness. For pharyngeal and laryngeal diphtheria of 48 hours duration, you can give 20,000 to 40,000 units. For nasopharyngeal lesions, you can give 40,000 to 60,000 units. And extensive disease of 3 or more days duration, patient suffering from bull neck, then you give 80,000 to 1,20,000 units. Antibiotics are very essential, and basic antibiotics now today, with Corynebacterium diphtheria not being present in society for such a long time, basic antibiotics are the best antibiotics. No need of giving high flow antibiotics. The basic importance of giving antibiotics is to terminate the toxin production, limit proliferation of the bacteria, prevent the spread of organisms to contacts, and to prevent development of the carrier state. So simple procaine penicillin 3 to 6 lakh units at 12-hourly interval is recommended to the patient who is able to swallow. Procaine penicillin, just basic penicillin. Either you can later afterwards you can first initially you give injectable penicillin. After that you can shift over to oral penicillin 125 to 250 milligram 4 times a day, or erythromycin 25 to 30 milligrams per kg per day is given whenever the patient is able to swallow. For the total duration of treatment requires to be 14 days, and clinical infection does not is not sure that the person will be immune. So we must ensure that the person is given immunization after he suffers from it and is given treatment for the disease. Supportive therapy is bed rest for 2 to 3 weeks. Avoid sudden exertion. Observe the patient closely for changes in rate and rhythm of heart. Antibiotics and sedatives may be given if required, and easily digestible, high-calorie food should be advised. Complications: toxemia and myocarditis. You have to give absolute bed rest and nursing care. For the toxemia, you might require to give hypertonic solutions of glucose 20%, and steroids. And if the person goes into congestive heart failure, then you give him digoxin. For treatment of paralysis, you ensure that you give the patient good nursing care. And for the pharynx, you may have to put a gastric tube and suck out the mucus, because the patient is unable to do that. And if there is respiratory obstruction, you would like to give some humidified oxygen, or if the obstruction is too much, then you may think of doing a tracheostomy. As far as contact is concerned, based on the immunity status, you have to either primarily immunization or booster can be given, or non-immunized can be given. For close contacts can be given prophylactic antibiotics, antitoxin, and active immunization. If the primary immunization has been done within 2 years, no action is required. If it is beyond 2 years, booster should be given. Contact should be placed under medical surveillance and examined daily for evidence of diphtheria for at least a week after exposure. Now, carriers can be the patients. Some of the patients may develop into carriers. Otherwise, if you detect carriers in the community, one should ensure that you give the patient erythromycin for 10 days. And Now, the prognosis depends on the extent of the membrane and the ability of the organism to produce the toxin. The immune status of the patient also is very important. If the membrane is limited to nostrils, toxicity is negligible. If membrane present on both tonsils, patient may develop palatal paralysis. If membrane extends beyond the tonsils involving palate and nasopharynx, patient may suffer from any or all of the severe complications. If there is hemorrhage, the prognosis is grave. Diphtheritic paralysis is temporary condition and recovery can occur. Now, prevention, the 4 key strategies which are required for prevention and control of diphtheria is primary prevention by ensuring high population immunity, that is, we give a herd immunity, strengthened surveillance, early diagnosis and high quality case management, rapid investigation and management of close contacts. So what do we do as far as prevention is concerned? We have to do health education, inform the patient about patient and his contacts as well as population about the disease, and do immunization, active and passive immunization. Active immunization, we have single vaccines, we have various types of single vaccine, but these single vaccines are hardly used nowadays. We have combined vaccines, which are DPT, that is diphtheria, pertussis and tetanus, or the DPT, which is with a whole cell pertussis, or DPT, which is with the acellular pertussis. Then you have DT without the pertussis element for children, for bigger children, which is there for booster doses, and a DT with a small d, which is there for adults. Please remember, now currently DT has replaced TT all over the country. Tetanus toxide is generally not available in the country. It is to be replaced by DT, and DT is to be given for antenatal mothers also. We were earlier giving 2 doses of TT to antenatal mothers. That is to be replaced with DT, the small dt. Okay. So DPT vaccine is two types which we have, plain and absorbed. The absorbed is usually done on mineral carrier, aluminium normally. Absorption increases the immunological effectiveness of the vaccine. The storage has to be done in 2 to 8 degrees. Temperature extremes may adversely affect the reusability of the vaccine. When issued to the sub-center, it should be used within a week. If you suspect that the thing is been frozen, use the shake test, shake it up and shake the control and test samples for 10 to 15 seconds, allow it to rest. Compare the vials. If you've got sediments which are there, do not use it. If the test sample shows much lower sedimentation rate than the control, the test sample is potent and can be used. If the vaccine is allowed to freeze, the link between the antigen and the aluminum adsorbent gets broken. Aluminum tends to come together in lumps and becomes heavier. This is why sedimentation occurs faster in a vaccine vial which has been frozen. The optimum age can be safely given as early as 6 weeks, and administration is given intramuscularly. Lateral aspect of the thigh, 0.5 ml, 4 weeks between first 3 doses, that is 6, 10 and 14 weeks. Booster is given at 18 to 24 months, and another DT booster is given at 5 to 6 years. Additional boosters every 10 years. Reactions may occur during immunization: pain, swelling, redness, difficulty in walking, and systemically you may get fever, lassitude, anorexia, vomiting. Child may have excessive crying, screaming spells, convulsions, and temperature may rise. If the temperature rises very high, then you're looking at a little bit of trouble. So you may have seizures, convulsions, collapse, difficulty in breathing. These are serious side effects. There are generally no very heavy contraindications except for anaphylactic or allergic reactions, and the P element which is there is the one which can cause problems, progressive you should consider. So anybody who has seizures, you may look at deferring the P element, so we give a DT. So then you can give various types of DT which is there. Elective immunization is into individuals greater than 6 months. So these are various types of vaccines. Unlike if you don't want to give the P element which is there, then you have acellular pertussis which can possibly be given. DT is given to people who are got children who are greater than 7 years old, and then capital D, and small d is now replacing TT everywhere. So it can be given because it's with a small t, because you got a smaller dose of diphtheria which is being given. And formal toxoid is by incubating the toxin with formalin, you get a formal toxoid which is there, which will retain the immunogenicity. And the absorbed toxoid, as I said, we generally absorb it with aluminium. Passive immunization can be given with horse serum, 500 to 2000 international units, given subcutaneously or intramuscularly. Therapeutically, that's for prophylactic. Therapeutic, we generally give 10,000 or 30,000 units, or can go up to 1 lakh units in 2 divided doses. Protection against diphtheria by administration of antitoxin is quantitative. You have to consider what is the benefit to the patient which is occurring, and then decide on it. That's all that I have to say on diphtheria. Next class we will be considering whooping cough. Please remember, today we must, I have removed my mask only because of the fact that we are today there facing you alone in this room. There is no one near me, and that's the reason why the mask is not there. Otherwise, please use a mask and use a mask properly. Thank you. All the best. Stay away, stay healthy, stay safe.